Beats Radio, scientists interviewing scientists. Canada is a worldwide leader in science and innovation. However, our communities need to be more connected to current scientific research in order to drive the future of scientific innovation. So what steps can we take to more actively engage and connect our community with scientists and vice versa? Innovation and discovery are at the core of the current efforts of our government, but science sometimes gets slightly complicated to understand. At Beats Radio, we will tackle this by having young scientists and early career researchers interviewing scientists and innovators. By dissecting science in simple terms, this will allow our community to better understand the importance of science for our country. Good morning, and thanks for tuning in to Beats Research Radio. My name is Hallie Arnott. I'm the Canadian Biomaterials Society Ottawa Student Chapter President and a graduate student in biomedical engineering at the University of Ottawa. Today I'm excited to be back here as your host on this episode of Beats Research Radio, streamed from an active lab at the University of Ottawa Heart Institute. Our goal here at Beats Research Radio is to communicate scientific research that's being conducted in the lab to the community. We hope that by doing this, we're able to engage people from all different backgrounds about how therapeutics, technologies, and other medical breakthroughs go from the lab to the clinic. The unique aspect about our show is that we have early career researchers and scientists interviewing other scientists and established researchers and clinicians. Before we get going with our interview today, I would like to thank the University of Ottawa Heart Institute, eLife, the Canadian Biomaterials Society Ottawa Student Chapter, the Beats Research Lab, and the Department of Biochemistry, Microbiology, and Immunology with the Faculty of Medicine at the University of Ottawa, who are supporting our endeavor here at Beats Research Radio. Also, don't forget to subscribe to our YouTube channel by clicking on the subscribe button below this video. So now to get started with our interview today, we have Dr. Newton-Cheh, who is here with us. Dr. Newton-Cheh is a complex trait geneticist and cardiovascular epidemiologist with the laboratory in the Cardiovascular Research Center and Center for Genomic Medicine at Massachusets General Hospital and Harvard Medical School. He is a practicing cardiologist in heart failure and the transplant section and cardiovascular genetics program at Massachusets General Hospital, where he cares for patients with advanced heart failure, post-heart transplant, and specifically those with familial dilated cardiomyopathy. In his lab, he investigates hypertension, QT interval variation, cardiotoxic drug response, and heart failure. Their lab leverages rapid growth of human genetics to identify genetic variants in genes known and previously unknown that underlie these diseases. They aim to translate genetic discoveries into an improved understanding of the human physiology through clinically focused research as well as animal studies and through cellular models. They also hope to define the role of genetics and other factors in predicting the patient risk of disease and response to different therapies. So thank you very much for joining us here today.
Great, thanks very much for the opportunity to come.
Great, so from reading a little bit about your background, I understand that after completing medical school, you then specialized in internal medicine and cardiology, but then you completed a postdoc fellowship in trait genetics, in complex trait genetics. Do you think you could explain to our listeners a little bit about why you made this transition into research and into genetics after working at the bedside with patients in cardiology?
Sure. I think when I was training in medical school and learning about internal medicine and cardiology, the Human Genome Project was first being reported, and it was an exciting time in genetics. Prior to that time, we really didn't know where all the genes were in the human genome, and didn't have a letter by letter sequence for the human genome. So I think in the early 2000s, when the first published human genomes were reported in about 8 or 10 people, it was only a small number of individuals who were
Right.
sequenced in detail. Um, that essentially gave us a roadmap for how to start undertaking genetic studies. And so I got interested early on. We happened to be a mile away from the Whitehead Institute Center for Genetic Research. It was one of the major drivers of the Human Genome Project. There were about 10 centers
Oh.
across North America and in Europe and Asia that contributed to that work. But there was a lot of genetic expertise that had been gathered together at MIT and Harvard. And ultimately, the Whitehead Institute Center for Genetic Research became the Broad Institute, supported by philanthropy. But um, much of my postdoc was conducted there early on. So I would say it was mostly serendipity.
Right.
We happened to acquire the tools to be able to study large numbers of human beings. Prior to that, because human beings have messy genomes,
Right.
we interbreed not based on similarity, and so
Right.
every individual has a unique genome, unlike animal models, mice or rats that have very defined genomes and are specifically bred to be easier to study genetically. Humans, because we have so much genetic variation, were harder to study before the Human Genome Project came out.
Okay. So before the Human Genome Project came out, were we studying in detail these animal models or?
We're largely studying animal models, and in cases where it was obvious that there was a likely genetic basis for a disease in a family, say multiple individuals in a family had a disease that was rare, unlikely to coexist within a family by chance, those studies that had very strong signatures of having a genetic basis had been studied using crude tools in the
Right.
70s, 80s, and 90s. Those did allow identification of some important genes, HMG-CoA reductase, which was the target of statins, that's allowed
Okay.
the reduction in risk of heart attack. The cystic fibrosis gene was identified in that time period using those cruder brute force
Models.
tools
Right.
that would take years to track down the gene underlying the disease. Whereas since 2000, the tools have enabled much more efficient genetic testing of
Okay.
large numbers of individuals.
And when the Human Genome Project started, did you say that there were large differences that were seen from the animal models to the human models, or?
I think what's become clearer over time is that while there are a lot of unique opportunities of studying animals, mostly because one can very precisely manipulate their environment, their diet, and their exposures. We can't do that to
With
human beings.
humans?
So, in many ways, many of the basic insights into mammalian or physiology in mammals comes from those animal studies. But what we've recognized is that, in fact, many times there's a great animal model that appears very similar to a human disease. And if we develop a drug based on that model and then test it in humans, there's been a lot of frustration that those drugs don't, in fact, have the effect that we expect because mice, as you may imagine, are not so
Right.
similar
Exactly.
to human beings. So I think the opportunity to use human genetics, where we can identify the genes that play a role in disease in human beings as opposed to other animals, have allowed the targeting of medications that are more likely to be beneficial in human
More
beings.
precise too. So, with heart failure, do you think you could tell us a little bit about what heart failure is and what the term ejection fraction means in terms of cardiology?
Uh-huh. Sure. So the job of the heart is to pump blood to the brain and all the other organs in the
Mm-hmm.
body. With each beat, the heart ejects blood, and it doesn't eject all of the blood in the heart with each beat. It's generally about half of the blood gets ejected, so that would be a 50% ejection fraction. Um, that's considered a normal pumping function of the heart.
Okay.
And in patients who have heart failure or congestive heart failure or cardiomyopathy, those are
Mm-hmm.
all synonyms, there can be a reduction in the amount of blood ejected with each beat because the heart is a muscle, and when it's weak, it can't do the same work that it can do
Right.
when it's healthy. So a reduced ejection fraction might be 20 or 30%, and patients with such reduced ejection fraction
Mm-hmm.
often will have symptoms of inadequate blood flow to meet the needs of the body,
Mm-hmm.
especially limitations to exertion. You
Mm-hmm.
might get short of breath walking upstairs or carrying groceries,
Right.
and can accumulate fluid that can cause swelling of the legs, fluid in the lungs that contributes to that shortness of breath, um, and predisposes to premature death.
Okay.
The heart failure can cause arrhythmias that can cause a cardiac arrest, or
Mm-hmm.
where the heart beats so rapidly that the blood pressure falls, and unless given a shock, a patient might not survive.
Right.
But also progressive heart muscle weakness, despite medications or other advanced therapies,
Mm-hmm.
can also cause patients to not survive due to their
Right.
heart failure with reduced ejection
Okay.
fraction.
So circling back to our genetics, and as well with this heart failure that's related to your ejection fraction, how does I understand that genetics is related to these two things in some way? Do you mind telling us a little bit about that?
Sure. It's actually been hard to study the genetic factors that contribute to heart failure.
Mm-hmm.
Um, Unlike, for example, the genes and proteins that contribute to cancer, cancer is much easier to study because
Mm-hmm.
typically we cut cancer out, and that means that you have tissue from the individual that can
Right.
be tested, where we can identify the genes and proteins that are
Mm-hmm.
activated in those cancers. In fact, it's difficult to get tissue from human hearts.
Heart.
One can do biopsies, but they have risk, and it's not done routinely. And
Mm-hmm.
so usually human hearts only become available for study after a
After death.
patient passes away,
Mm-hmm.
or in small numbers for patients who have heart transplants. Um, so more recently, using human genetics has allowed us to identify a set of genes and proteins that,
Mm-hmm.
when altered, can cause the heart muscle to fail over time. Um, the heart never gets a break. You're
No.
born and your heart is beating, and it beats roughly once a second, and there's no rest for the heart other than
No.
a few milliseconds within that time period. And so the heart failure takes years or decades to develop in patients who have a genetic basis for it. It often won't manifest until age 40 or 50 or 60,
Mm-hmm.
often in combination with other factors that can cause it to
Okay.
manifest. Um, I think most recently there have been technologies. It cost billions of U.S. dollars to sequence the first 6 or 8 people's human genomes.
Wow.
Now it costs about $2,000 or $3,000
Okay.
to sequence an entire genome. So it's an
Wow.
incredible advance that's allowed the newer technologies to
Right.
sequence genomes in patients who have heart failure with reduced ejection fraction. And so,
Right.
in in families that have uh, uh, heart failure, about a third of the time we can identify the genetic basis
Okay.
for that congestive heart failure. And there are a few genes that turn up again and again
Mm-hmm.
as having mutations or DNA sequence changes that contribute to that risk.
Okay.
And so, only in the last 10 or 15 years have we been able to use genetics to study families. To say one individual within a family presents with cardiomyopathy, now we can study their family members and find early manifestations of
Mm-hmm.
heart muscle weakness, and we can genetically test that first individual,
Mm-hmm.
and then test family members if we are able to identify the cause, so that they can
Right.
be monitored prospectively
Mm-hmm.
before they manifest disease,
Right.
and we can intervene and give them medications to try to prevent
Okay.
their developing the manifestation. Similar to women getting mammography
Mm-hmm.
to screen for breast cancer, if we recognize people who are at increased risk for heart failure, we can screen them with ultrasounds to
All
monitor
right.
their heart function.
Before. So this genetic testing that you're doing, does it require a whole day for this patient to come in, or if somebody comes in and they're presenting with their heart failure, is it routine for the rest of the family to get checked out, or is it only in certain cases where this would happen?
The general recommendations are that every patient who presents with heart failure with reduced ejection fraction, if it's not due to coronary artery disease, because there
Right.
are many,
Other
many
types,
factors that
yeah.
contribute. Heart attack certainly can cause heart muscle weakness when the heart
Mm-hmm.
muscle dies. Um, but in patients who don't have coronary disease or another identifiable cause, the general recommendation is to screen all first degree relatives. That would be
Mm.
parents, siblings, and children with an EKG that monitors the
Okay.
electrical activity and an ultrasound that monitors the pumping function roughly every 2 to 5 years,
Okay.
if a genetic cause is not known in that family.
Mm-hmm.
Um, and as far as the genetic testing part, it's actually pretty simple. You'll know from television shows that you can get a little bit of DNA from someone's hair, or
Right.
if they're drinking from a glass,
Mm-hmm.
the detectives can
Yeah.
swab it to get it. So it's actually quite easy to get DNA from blood. So
Okay.
typically it's a blood sample, about two teaspoons of blood
Okay.
are sufficient, get sent to a commercial laboratory, and then about 4 to 6 weeks later, the results are returned, and either a genetic cause is identified in about a third of cases, or in about two-thirds of cases, a genetic cause cannot be identified.
Identified. Okay.
That doesn't mean that there
That
isn't a
doesn't mean
genetic
that it's not
basis.
there.
It just means that it's not. We don't know.
Known. Yeah.
We don't know all of the genes that can cause cardiomyopathy, and we don't know how to recognize
Mm-hmm.
all of the genetic changes that could be the cause.
Right.
If it changes an amino acid, which is the sequence of proteins, then that's one way we can recognize the
Right.
likelihood that it contributes.
Okay.
But there are many genetic factors that don't directly
Mm-hmm.
influence amino acid sequence,
Right.
and those are harder for us to
For us to.
recognize.
So is it the combination of like these combinations when you send the blood out for genetic testing? Would this be these certain sequences? Do we know all of them, or do some pop up and we say, well, we've never seen this before? Is that something that does occur?
Typically, what's done is there's a panel of 20 to 30 genes that gets screened, and then letter by letter, because each person inherits one copy of each gene from their
Right.
mother and one copy from their father. Letter by letter, those two copies of the gene are determined, and anytime there's a new genetic letter or sequence that's observed, it's compared to what we know for that is generally prevalent in humans. And
Okay.
then if that's been seen before in people who have heart failure,
Mm-hmm.
then it's easier to confirm that it is the likely cause. Or if it
Okay.
has a very strong effect on the gene,
Right.
such that no protein is produced by that gene when that genetic change is observed.
Okay.
Those are ways that
Mm-hmm.
that we can determine that it's the likely cause in that individual.
Okay. On average, would you say that when someone comes in and they're presenting with heart failure and you think that it could possibly be genetic, contacting the family members, would you say that more often than not people will come in and do the testing, or do you find that some you don't get some response sometimes, and those people don't actually get in contact with the hospital or medical professionals in order to do this testing?
I think it varies. Many of the genetic centers are in cities,
Okay.
so my experience in America is that people in cities tend to be more likely to travel, and so it's often the case that families are widespread,
Okay.
and not necessarily so connected. In outside of cities and more rural communities, families tend to stay locally for and tend to get care at the same places. So it's a little easier to recruit family members. We can't reach out directly to family members because they're not our patients as doctors. So we actually try to help the patient become an advocate and explain to their family what the genetic basis of their condition might be, so that they can explain and try to encourage them to seek medical help. So it's not an optimal system. We don't. There's a lot of fears of Big Brother and preservation of privacy, and so we really rely on individual patients explaining to their families and trying to help them understand that they may be at risk, even if they don't recognize that risk.
Wow. Okay. And what would be some of the genetic indicators that you would see in patients with hereditary heart failure? Are there specific ones, and does it vary from person to person, or would you say that maybe with females there's a genetic indicator that's common versus males, or even just different ethnicities? Do you find there's any commonalities?
For genetic factors that individually are strong enough to cause disease, typically they are new and private to individual families. If a parent has a disease and has a genetic variant, there's typically a 50-50 chance that they pass it on to each of their offspring. It doesn't tend to differ by sex or necessarily by race, because genetic changes are arising all the time, and so more commonly it's a new genetic variant in each family that gets identified. Although as we're doing more and more sequencing, we are finding that some genetic changes appear to arise repeatedly for gene regions that are more predisposed to having mutation or change.
Wow, very, very interesting. I learned a lot during this interview, this first segment of our interview. We will be back with our second segment with Dr. Newton-Cheh in just a few minutes. So thank you for tuning in.
Right.
We realize when you come for an open heart surgery that this is met with some anxiety. It's obviously something that no one really wants to undergo. However, it is very safe. I often compare it to taking a flight across the Pacific Ocean. There's a lot of technology involved. There's a lot of standard protocols and procedures, but they're all oriented towards making this experience the safest it can be.
Once I was behind the curtains, they were very, very thorough in explaining to me where I was going, who was in, the people that would be there. They introduced me to the surgeon. They introduced me to all the different nursing staff that would be in the room. And they made me feel at ease just by letting me know I was in their hands.
The good thing is with cardiac surgery, it has become very, very safe. We bring together the latest improvements in technology, in infrastructure, and the way that things are done towards enhancing the safety aspect and the comfort aspect for the patient and his or her family.
I needed to go into the Heart Institute to have a catheter ablation. They walked me into the cath lab. The rapport between the folks who were there, the staff that was there, you could really get a sense that they were working together. There was a lot of banter in the room. It was very comfortable. I think that 10 minutes did so much to reassure me about what was to come, probably as much as the research and the reading and the preparation I had done before.
When patients come to the Heart Institute for the first time, they'll be struck by our team approach. This is a core component in how we do things here. We all work together with the same goal to basically provide the best care possible for our patients.
I remember the paramedic was with me telling me, Mrs. LaBelle, You're going to the Art Institute. When I arrived to the hospital, they told me, Mrs. LaBelle, you are having a heart attack. And I just wake up after that. I was in the recovery room. And I survived. Had surgery. I was alive. To me, it was a miracle.
Patients come to us after having open heart cardiac procedures. There's a team of dedicated professionals who will provide you with the expert care that you require, all of them with a specialty in critical care and in looking after patients who are the sickest in our hospital.
I was going into the unknown, and I was very scared. But I also knew the care that these individuals would offer and the skills they presented.
I have confidence. This is the right place to be at the Art Institute.
I wouldn't be living the life that I'm living without the care that I received at the Heart Institute, and the passion and the commitment and the energy that the healthcare team brings to the care that they give you is amazing.
Good morning and welcome back to Beats Research Radio. Today I have Dr. Newton-Cheh sitting here with me. Dr. Newton-Cheh is a complex trait geneticist and cardiovascular epidemiologist with a laboratory in the Cardiovascular Research Center and Center for Genomic Medicine at the Massachusets General Hospital and Harvard Medical School. So to jump back in with our conversation here, we're going to get into a little bit about cardiovascular genetics, and the topic is, when will we know, or when can we use genetics and use it to tell us what medications to prescribe to patients with cardiovascular diseases? So do you think you could tell us where we currently are in terms of prescribing medications to patients with cardiovascular disease, and whether or not we are using genetics yet?
So by and large, we're not.
Okay.
I would say the majority of medications are prescribed to broad populations of individuals. Most clinical trials enroll patients who have conditions that are common,
Okay.
and each individual within those studies may have their the disease develop through different risk factors that contribute to it, both genetic and non-genetic, such as smoking or diabetes or obesity or hypertension. So by and large, most drugs are not targeted to individuals based on their genetics. That could change. I think it remains to be seen. I've done a lot of studies of blood pressure, and from those studies we've found as many as 500 to 1,000 different genes contribute to blood pressure regulation. And that really means that while hypertension or high blood pressure is very common and leads to stroke and heart failure and heart attack, in fact, in each individual, it's typically a combination of hundreds of genetic effects that contribute to risk. And so it's very unlikely that, for example, that we will use blood pressure medications tailored to individuals based on their genetics. It's just the genetics are so complex that it's unlikely that one genetic effect will indicate that one medication is likely to be beneficial. Where it's probably the most useful would be cancer. I think we know the genetic basis of cancer. That's not necessarily an inherited risk. There are inherited syndromes like BRCA1 and BRCA2, for example, that are risk factors for breast and ovarian and other cancers. But what we can do in cancer, for example, is if we identify the specific genetic factors in the individual tumors that fuel the progression of cancer and metastasis, then those can now be targeted with very targeted therapies that are less likely to be toxic compared to general chemotherapy. And so cancer is probably the best example of tailoring or personalizing the therapies that we use for individuals. I think cardiovascular disease is much further away.
It's harder.
Even if we consider the genetic factors that cause congestive heart failure, we still treat the majority of those patients with the same cocktail of 3 medications, regardless of which genetic factor is the cause.
Okay.
So there are some differences. We're starting to gather larger and larger databases to be able to understand that.
Okay.
But at the moment, it's more a promise or
It's
a
on the
future.
research side
Yeah,
right now.
it's not yet clinically
Okay.
applicable in cardiovascular
So
disease.
in your lab, are you guys working on this and how these genetics can be applied in a clinical setting and how they can be applied to possibly tailoring drugs to a specific person? Is that something that you're working on?
Yes. One example is we have done studies looking at measures on the electrocardiogram
Okay.
that track with risk of cardiac arrest, a cause of sudden cardiac death. And there are about 100 to 120 medications that are currently in widespread use
Okay.
that have as a side effect that they can prolong the QT interval measured on the EKG and increase the risk of arrhythmias. We still use those medications if the benefit of them is great enough and if the risk of those life-threatening arrhythmias is low enough. But we've now identified hundreds of common genetic factors that alter the QT interval on the electrocardiogram.
Okay.
And we're now testing an aggregation of those genetic variants in people who are admitted to the hospital to be started on a medication that has as a side effect QT prolongation and arrhythmia risk. And we're doing those current trials to try to define how much of the risk of arrhythmias or cardiac arrest from those drugs is explained or can be known from these common genetic factors. With an idea that if they play a strong enough role, it will be possible to test these genetic factors before prescribing a medication that might have this side effect and avoiding or choosing a different medication for individuals who are genetically at high risk. So that's one example where our lab is trying to bring genetics into clinical relevance, but mostly on the side of avoiding toxicity rather than identifying individuals who might benefit from a specific drug.
So cardiotoxicity, this is something from taking drugs, so somebody can develop cardiotoxicity, or would it be something that is immediate?
Well, commonly, for example, this type of cardiotoxicity often acts in combination with other factors. So, in fact, women are at about 2-fold increased risk of having this side effect of medications compared to men, because women have longer QT intervals for factors that are not entirely understood. Patients who have congestive heart failure, patients who take diuretics, patients who have low potassium or other electrolyte disorders, all of those can interact with genetic risk and or with the drug exposure to increase the risk of arrhythmias.
Oh, great. So this testing for genetics early on and being able to know what types of based on somebody's genetic makeup, if they are at risk or not for this cardiovascular disease, do you think we will be able to reduce on a large scale the progression or even the occurrence of heart disease in our world today?
It remains to be seen.
Right.
I would say, to be totally honest, you know, when I started this line of study, when I first finished my training, I was very optimistic that genetics would unlock
all the doors,
all these clues, and we would be able to tailor individual therapies to individual genetic makeup. I'm a little less certain, having done it now for a couple decades. I would say it's still possible that approaches like widespread use of cholesterol-lowering medications, widespread use of blood pressure-lowering medications, given broadly to the public at large, may be a better way for specific diseases to reduce risk. It may be that for specific diseases, genetics or knowing one's genetic makeup could be more beneficial. So I think there's a lot of active research in this area, and I think in the next 10 years we'll have a better sense for common cardiovascular disease, how much risk we can lower by knowing people's genetic makeup, and how much risk we should lower just by broad campaigns to
Right.
make people aware of what is their cholesterol. If it's
Mm-hmm.
high, treat it. What is their blood pressure? If it's high, treat it. It's possible that may be more
A
effective
better
in some
target.
cases.
When you say a widespread, giving this medication on a large range of people, would it be somebody who is presenting with some sort of indication that they could develop a cardiovascular disease, or is this anybody? Are we
Well,
just deciding
this
that?
is why I bring this up, because heart disease, especially coronary artery disease, but
Mm-hmm.
also congestive heart failure, these are decades long in
In
development.
development,
So
right?
we know from studies from the Vietnam War that soldiers who died from trauma had the beginnings of atherosclerosis in the arteries of their heart. So we know
Okay.
that even though heart attack tends to occur in people's 40s, 50s, 60s as they get older,
Right.
that it's a lifelong process.
Mm-hmm.
These are silent processes. People can't feel when their blood pressure is high. They can't feel when their cholesterol is high.
Mm-hmm.
So in many ways, the reason I refer to public health is these are broad campaigns
Mm-hmm.
in the same way that we try to encourage people to eat nutritious diets.
Mm-hmm.
These are not targeted. These are broad. You see them in television and other
Right.
media. So they're not people who know individually that they have risk. I
Right.
can't say that the uptake by the public has been great. It's
Yeah.
there's a fair amount of fad and focused on uh, nutritional supplements that have very little proven benefit.
Mm-hmm.
And I think helping educate the public about the risk factors that contribute to risk of disease
Mm-hmm.
is an important component of public
Right.
health, both a genetic risk and other exposures such as smoking.
Right. And you did complete a Master of Public Health at the Harvard School for Public Health in 2004. Was that
Uh-huh.
kind of why you decided to pursue that, and just seeing what's happening on, the macro scale and saying, all right, we need to, look at this on more of a larger standpoint?
It's my time studying at the Harvard School of Public Health certainly highlighted for me and gave me broader exposure to
Mm-hmm.
the opportunities in public health. It's a broad field. I wanted to get enough understanding of study design,
Right.
epidemiology, and statistics,
Mm-hmm.
and those are part of public health. And so my initial desire to study at a school of public health was mostly to acquire those skills. But in the
Mm-hmm.
process, I did come to better understand socioeconomic, racial, cultural determinants
Of health.
of health as well.
Oh. So, back to our cardiovascular genetics. Aside from the medicinal approaches that we're talking about, do you think that we would be able to use genetics to possibly prescribe a young person who has a predisposition for a cardiac disease, something like more physical activity or a certain diet that restricts a certain type of food early on, without even knowing if they would develop it, but if they might have a possibility? Would telling this person to do a certain type of more physical activity, would that help?
Well, I can give you one example.
Mm-hmm.
So, titin is a gene that it plays a structural role in heart muscle cells.
Okay.
And we know that something on the order of 15 to 20% of patients who have familial dilated cardiomyopathy or heart failure will have a genetic change in the titin gene.
Okay.
We now know that inheriting that genetic change can interact with things like excessive alcohol use
Okay.
or exposure to certain chemotherapy drugs or even pregnancy
Okay. Well.
to cause cardiomyopathy to become manifest or to develop.
Well.
So in the case of titin, for
Mm-hmm.
example, we know that when we identify through family screening with genetics, an individual has no current manifestation of cardiomyopathy, that we can tell them, look, we know that you can lower your risk by avoiding excessive alcohol use
Mm-hmm.
And if you're getting chemotherapy, to consider a form of chemotherapy that's less likely to be cardiotoxic. Those are starting to become realities.
Okay, that's
It's
good.
easier for us to recommend avoidance of alcohol excess because there are a lot of negative effects of it, not just on the heart. So it's there's a little downside to recommending against excessive alcohol use, but we certainly don't recommend against pregnancy, and we do counsel patients who are genetically at risk for cardiomyopathy to have a screening ultrasound of their heart before they become pregnant and monitor them for symptoms during pregnancy. So that would be one
Just
example
getting
where,
ahead of whatever might possibly occur.
intensive
that's great.
surveillance and potentially early therapy to avoid it's becoming more severe.
Okay. So now moving on to, I guess, the pharmaceuticals. Would you say that pharmaceutical companies are adapting to this genetics, to these genetics, and prescribing medication based on genetics? Or are they starting, I guess, are personalized medicine approaches, are they on board or off board, or is it, do you think it'll take a while for
Well,
it to...
I think it's challenging for pharmaceutical companies. They certainly, you could imagine if you were a pharmaceutical company and
it's expensive.
it was costly to both do the research and develop and then market and distribute these drugs, that if you're a drug company, probably your preference would be to identify therapies that could be broadly applicable to large populations rather than unique for specific individuals. But for severe diseases that have no other therapeutic alternatives, such approaches are currently being developed where they're very targeted and focused on genetics. But the majority of pharmaceutical development is focused on broadly applicable therapies. But I would say that where we had spoken earlier in the first segment about a failure of model organisms such as mouse or rat or other organisms to recapitulate or reproduce the human effect. Human genetics has now been taken up by many pharmaceutical companies as a way to develop confidence that targeting a specific protein is more likely to be beneficial, to allow them to prioritize which potential candidates they pursue. Doing large clinical trials, especially for cardiovascular disease, typically can cost $100 million. If there are 10 or 20 possible therapies that might be pursued, I think pharmaceutical companies are now prioritizing pursuing those few candidates where there's strong human genetic evidence to support their relevance to human disease.
Right. So is this kind of on the, I might be left field here, but for the vaccines, like choosing that vaccine, does that come from, choosing what strains and all that for the flu? Would that kind of be along those lines? And then the pharmaceuticals, they develop that vaccine based on those specific, what happened last year, that kind of thing?
In that case, for example, if you consider typical pandemic influenza, the flu that I get vaccinated for every September, because I take care of transplant patients. A, I don't want to get the flu. B, I don't want my kids to get it. But C, my patients are at great risk from it. That influenza vaccine is typically targeted to the influenza strains, which are genetically defined, that are observed 6 to 9 months earlier, commonly in China or Southeast Asia. Those often become the form. So those are targeted to viral genetic signatures as opposed to human genetic.
But they still look on the large scale, I guess, on who it's going to help, and they're not totally.
That's correct.
Targeting the specific.
That's correct.
Person,
it's not targeted to individual people.
Okay, very, very cool. Thank you very much for talking to me about cardiovascular genetics. I have learned a lot today. So please subscribe to our YouTube channel, and you can also find this interview with Dr. Newton-Cheh on our Spotify as well as on iTunes. Thanks for tuning into Beats Research Radio. This week, I'd like to thank the University of Ottawa Heart Institute, eLife, the Canadian Biomaterials Society, Ottawa Student Chapter, the Beats Research Lab, and the Department of BMI at the Faculty of Medicine at the University of Ottawa. So thank you very much, and we'll see you next week.
Great, thank you.
Beats Radio, scientists interviewing scientists. Canada is a worldwide leader in science and innovation. However, our communities need to be more connected to current scientific research in order to drive the future of scientific innovation. So what steps can we take to more actively engage and connect our community with scientists and vice versa? Innovation and discovery are at the core of the current efforts of our government, but science sometimes gets slightly complicated to understand. At Beats Radio, we will tackle this by having young scientists and early career researchers interviewing scientists and innovators. By dissecting science in simple terms, this will allow our community to better understand the importance of science for our country.